Hello everyone, I am Dr. Nora El-Sheikh and I'm happy to discuss with you Pheochromocytoma. This dark grayish tumor, which is what the word pheo means, is a rare tumor which arises from the adrenal medulla, and it rarely arises from the extraadrenal sites and is then referred to as paragangliomas. They usually arise between the age of 30s to 50s and are usually a part of hereditary syndrome. So what are catecholamines? They are hormones secreted in response to stress, such as fear, fight, and flight, and include mainly norepinephrine, epinephrine, and dopamine. There is the famous Pheochromocytoma 10% rule, which is that it is 10% bilateral, 10% malignant. It occurs 10% in children, and in 10% of the time it is of extraadrenal origin. There is 10% recurrence rate and is found as incidentalomas in 10% of the cases. Let's discuss the presenting symptoms of pheochromocytoma. They are usually forceful heartbeats and palpitations, pallor, throbbing headache, sweating, and dyspnea. These symptoms usually appear in the form of attacks or episodes known as spells. However, in between the attacks, there is generalized chronic sympathetic overdrive, including headache, nausea, vomiting, constipation, hypertension, weight loss, palpitation, tremors, generalized increasing sweating, and hypertensive retinopathy and congestive heart failure are also coexisting in many cases. So when to suspect pheochromocytoma? There are some important features that should alert us to link them together to look for a pheochromocytoma, such as hyperadrenergic spells, which are usually self-limiting, resistant hypertension, especially paroxysmal and orthostatic, and if in younger than 40 years of age, and if these symptoms run in the family, or an adrenal incidentaloma is discovered. Differential diagnosis of pheochromocytoma includes panic attacks that are very similar as self-limiting episodes, cardiac arrhythmias, angina causing fear of death, also known as angioedema, beta-adrenergic antagonists, thyrotoxicosis, flushing spells and attacks such as those that occur with postmenopausal symptoms or with carcinoid tumors, pancreatic tumors, and with hypoglycemia. The most accurate test that would be 24-hour urine collection sample for fractionated metanephrine measurements. Serum fractionated metanephrine levels is a less accurate test and more practical in children. There is also the clonidine suppression test and is used when previous tests show less than 2000 pg per milliliter, and its normal response is defined as catecholamine levels below 500 pg per milliliter. Of course, the next step would be imaging. Before that, I would like to show you the list of drugs that should be avoided in the 24-hour collection sample of catecholamine and metanephrines to avoid the false positive results. Imaging includes CT scan with contrast of abdomen and pelvis, similarly MRI, and a low radiation dose nuclear medicine scan such as MEDA, iodo, benzyl guanide, dotatate PET scan using gallium-68, and regular PET scan using 18-fluoro-D-glucose. So most famous syndromes that include pheochromocytomas are men type 2A and B, von Hippel-Lindau, neurofibromatosis, and other sporadic tumors. Most of these are actually autosomal dominant diseases. It is very important to diagnose pheochromocytoma to avoid intraoperative blood pressure liability, which becomes very challenging for the anesthesiologist, and especially if the patient presented as an emergency case or to the ICU department. Also, it is important to know that any genetic syndrome involved for future generations, and finally to avoid long-term complications such as cardiac failure, pulmonary edema, or metabolic acidosis. So when to suspect malignancy? There are general signs of malignancy such as general fatigue, unexplained weight loss, change of skin color and texture, and symptoms according to metastasized organs. However, there are histopathological signs of malignant pheochromocytoma, such as that it is larger than 5.5 centimeters, there is capsular or vascular invasion, periadrenal adipose tissue extension, tumor necrosis or cell spindling, increased cellularity or atypical mitosis, nuclear polymorphic changes, and 24-hour urine catecholamine test less than 2.1 milligram per day per centimeter is usually involved with malignancy. To treat and cure pheochromocytoma, a multidisciplinary team, including an experienced endocrinologist, skillful anesthesiologist, practiced surgeon, and veteran oncologist, are highly needed to personalize a management plan for each case, depending on the size of tumor, probability of malignancy, and general health condition of the patient, using one or more of the options below. Surgical resection of the tumor is the main cornerstone of the treatment. Combination chemotherapy using cyclophosphamide in combination with methotrexate or vincristine, and meta-iodobenzyl guanide radiotherapy is also very useful. So preparation for the operation is the key to a successful result and smooth intraoperative procedure. First, there is preoperative control of blood pressure. This includes alpha adrenergic blockers for 1 week preoperative, usually in the dose of 10 to 20 milligram twice per day. Beta adrenergic blockers are then used 2 to 3 days preoperative, targeting heart rate between 60 to 80 beats per minute. Calcium channel blockers are also very useful, around 30 milligrams twice per day. And finally, as a last resort, catecholamine synthesis inhibitors are used in resistant hypertension. Intraoperatively, skillful anesthesiologist is highly needed. There is IV anesthesia such as fentanyl, sufentanil, and ramifentanil. Inhalation agents such as isoflurane and sevoflurane are the most preferable. And of course, as usual, propofol single shot is preferable at the beginning of the operation for a smoother laryngoscopy and intubation. And intraoperative mortality rates increase with unprepared emergency or undiagnosed pheochromocytoma cases. Post-operatively, it's very important to know what to expect. Immediate post-operative hypertension can exist due to recovery from anesthesia or pain. Catecholamine rise occurs 7 to 10 days post-operatively due to stress of the operation. And reactionary hypoglycemia is very dangerous and serious and should be dealt with for at least the first week post-operative. Thank you very much for your time and for your attention.